In this session, we will address the challenges and some possible solutions to implementing an effective bladder care program in the long-term care setting. I want to begin by talking about some of the challenges associated with bladder care and long-term care. First of all, this is a high-risk population for urinary incontinence. When you look at the population in long-term care, most of them are older. Aging in and of itself causes changes in bladder function that increase the risk for urinary frequency and possibly for urinary incontinence. One change that occurs is a reduction in bladder capacity. So we know that a person whose bladder capacity was 400 milliliters when they were 40 or 50 may find that at the age of 70 their bladder capacity has diminished to 300 milliliters. This obviously translates into increased urinary frequency. Another change that occurs is a reduction in bladder contractility. The bladder is a muscle, and over time its ability to contract forcefully and to completely evacuate the urine declines. So early in life, normal bladder function involves very forceful contraction and very low post-void residual volumes. But with aging, the bladder contracts less forcefully, and it's common for elderly individuals to have much higher post-void residual volumes. Some urologists say even if their post-void residual is 100 milliliters to 200 milliliters, they don't worry unless the resident is symptomatic. However, from a functional standpoint, this increase in post-void residual volume is significant to the individual. Let's go back to our person who has a bladder capacity of 300 milliliters. If he or she voids only 150 milliliters, that means that they leave the bathroom half full, and in a very short period of time, they'll have to go back. So you can see that the combination of reduced bladder capacity and reduced contractility results in a significant increase in urinary frequency, possibly in urinary urgency, possibly in leakage, and definitely in nocturia. And these are very common complaints from elder individuals in long-term care or at home. Additional changes, a reduction in mobility. Most residents in long-term care have some impairment in mobility. Many of them are dependent on assistive devices such as walkers or canes. Some of them cannot ambulate without assistance. That means that it is going to be difficult or impossible for them to get to the toilet in a timely manner and to prevent incontinent episodes. Probably a lot of you have seen patients who sustain falls, trying to get out of bed, trying to get to the bathroom because they were aware of the need to void. So mobility issues are a major factor contributing to urinary incontinence. The next factor on the slide is cognitive impairment, and this is equally or even more important. Many of our elders in long-term care do have some degree of cognitive impairment. That means they're going to have trouble problem-solving the steps required to get to the bathroom without losing urine on the way. Medications are a common issue. Many residents in long-term care are on as many as 10 medications, and some of those medications can have a profound impact on bladder function, such as diuretics. And then finally, as you see, hormonal changes. Men in long-term care are high risk for prostatic hypertrophy. Prostate hypertrophy can cause problems with urinary retention, urinary frequency, urinary urgency, and leakage. Females in long-term care are almost always postmenopausal, if they are not receiving any type of hormone replacement, they're very high risk for atrophic urethritis and atrophic vaginitis. The atrophic urethritis causes increased urinary urgency and frequency because of the inflammation at the level of the urethra. In addition, the estrogen deficiency makes it harder for them to maintain urethral closure during periods of bladder filling. So all of these factors taken together means that the long-term care population is a population at significant risk for urinary incontinence. That doesn't mean that incontinence is normal and that it should be accepted. It just means that these individuals are higher risk and we have to assess for risk factors and intervene appropriately. Now, the types of incontinence that are commonly seen in long-term care go right back to the factors that we've been discussing. It's fairly common to have residents who report urgency, frequency, nocturia, and possibly leakage all the way to the bathroom, the syndrome known as overactive bladder. It's equally common, or possibly more common, to see individuals with functional incontinence caused by cognitive impairment. By definition, functional incontinence means that my bladder works, it stores, it contracts. My sphincter works. The reason I'm incontinent is because I cannot recognize bladder filling and carry out the steps necessary to get to the bathroom in a timely manner. So cognitive impairment, very, very significant when we look at continence and incontinence, and functional incontinence due to cognitive impairment is a very common type of incontinence in the long-term care setting. It's also a type that can frequently be managed effectively with some simple interventions. A third issue, one that we have also discussed, is functional issues such as mobility issues that interfere with that individual's ability to toilet effectively and independently. Many patients with mobility issues are essentially dependent on the staff to help them get to the bathroom in a timely manner. Major implications for staff education and for establishment of routine toileting programs. We'll come back to that. And then finally, we have to recognize that there are residents in long-term care who are at risk for retention, either because of reduced contractility of the bladder, because of long-standing diabetes and autonomic neuropathy that further reduces bladder contractility, because of medications, because of prostate enlargement. A number of factors can cause urinary retention. So that's something that we always want to screen for. Now, another challenge that we have to be very aware of and we have to address effectively is the long-term care culture, and specifically the attitudes and beliefs about continence that are very common in long-term care. Studies across the globe, doesn't matter which country you do the study in, what you're going to find is that it is very common for long-term care staff to consider incontinence a totally normal aspect of aging, and furthermore to consider that diapering, that use of absorptive products, is the best way to manage these patients. I read one very interesting study. This actually involved acute care. And they were looking at the percentage of patients who fell into the age range of elderly, over 65, who were placed in absorptive products during hospitalization, despite the fact that they were totally continent. This actually, I believe, was in Israel, and over 10% of continent elderly individuals were routinely managed with absorptive products when they were in acute care. So it's not just long-term care where we run into these attitudes, but these attitudes are extremely prevalent in long-term care. The interesting thing is it doesn't matter which level of provider you talk to. Whether you do a survey involving nursing assistants, licensed providers, physicians, or administrators. They consider that, well, you know what, they're old, or they're confused, or they have less mobility, or, you know, what do you expect at this point in their lives? Of course they're going to be incontinent. That acceptance of incontinence as a normal aspect of aging is in direct contrast to everything we know about maintaining normal function. And obviously, it makes it much harder to implement an effective bladder management program if everyone thinks it's not necessary. The other thing that contributes to this culture of diapering as opposed to toileting, diapering as opposed to any attempt to restore or maintain continence, is just the care routines. So if you talk to providers in long-term care, a lot of times they'll say, well, you know, it's faster, it's more efficient if we just put them in diapers, check them every 2 hours, change them. We can do that quickly. It's much faster than having to get them up and take them to the toilet. So you see, they're thinking from the perspective of what's easier for the staff, not what's better for the patient. All of this is very common in the long-term care culture. Now, the interesting thing is, if you talk to patients and if you talk to families, many of them also believe that incontinence just goes along with aging and that diapering is the best approach. So there's a tremendous need for education, not only of the long-term care staff, but also for patients and families. Other issues that we have to be aware of, staffing can certainly be an issue. Many times long-term care facilities have very low staffing ratios. And that means that when we're putting together a bladder control program, we have to be very careful to be realistic and to focus our interventions in dealing with patients who are most likely to benefit. And I'm going to show you exactly how to do that. Okay, so we've talked about the current mindset in long-term care that most people believe incontinence is normal. They're not too concerned about it. The issue is put them in diapers, change their diapers, take care of their skin. Now I want you to contrast that to the expectations established for long-term care facilities. There are expectations that if I admit my mother to long-term care, that I can expect that that agency will do everything possible to maintain her functional status at the highest level possible. That is the expectation, that we will optimize functional status in all areas, mobility, continence, nutrition, skin, across the board. That's what we're supposed to be doing for our residents. Now, what does this translate into? Very specific expectations in regards to bladder management is, first of all, residents should not be managed with indwelling catheters unless that catheter is medically necessary. And we'll come back to what makes the catheter medically necessary. Secondly, we should not be managing patients with diapering unless they are immobile or unable to respond to toileting cues. For residents who are ambulatory with assistance and who can respond to voiding cues, they should be toileted, not managed with diapers. Okay, now I want to come back to a very practical, structured approach. If you are the continence nurse or the wound ostomy continence nurse or the ET nurse in a long-term care setting, either as a staff member or as a consultant, how do you go about putting together an effective bladder management program for that agency? And it has been very well defined. I'm going to go through step by step what needs to happen. These are the key elements of an effective bladder control program. First of all, everyone should be screened for bladder problems upon admission to the agency and at routine intervals thereafter. In addition, if there's any major change in function, for example, if a resident has a stroke and then is readmitted to the agency, they should definitely be reevaluated. So you do the screening assessment, which takes only a few minutes. Then residents who are identified on that screening assessment as having some type of bladder control problem should undergo a more thorough assessment, a focused assessment of bladder function. And we will go through exactly what that focused assessment involves. Once you complete that focused assessment, then you're going to synthesize your data. You're going to determine what type of management protocol this resident needs. If you have a resident who has a catheter that is medically necessary, it will be important to put that resident on a meticulous catheter care program. If you have a resident who has major mobility issues and who requires toileting assistance to maintain continence, that's the type of program you will initiate. If you have a resident with some degree of cognitive impairment and possibly some degree of mobility impairment, but that resident can be toileted with assistance and that resident can respond to voiding cues, that patient or that resident should go on a routine toileting program. And then finally, you're going to have patients who fall into the last two categories. And that is, there will be patients who are totally immobile or who have severe cognitive impairment and who are not able to respond to voiding cues. And those residents are appropriately managed with absorptive products and skincare. And finally, you'll have a few very high-functioning residents who are cognitively intact but complain of urgency and frequency and nocturia. They will benefit from behavioral therapy. So now let's talk about each element of the program in a little more detail. So let's talk about the screening assessment first. You can develop a very simple form that is part of your admission assessment and your routine follow-up assessment. And these are the questions that you should be asking. First of all, does this resident come with an indwelling catheter? And if so, is that catheter medically necessary? We'll come back to that. Secondly, at the time of admission or at the time of repeat assessment, is this resident having any problems with urinary leakage? Another question to ask them is, do you ever use pads to help protect against urinary leakage? So you can ask about leakage, you can ask about pad use. If they respond positively either to questions about leakage or to questions about pad use, they should undergo further assessment. You want to ask the resident at the time of assessment, when you urinate, do you always feel as if you empty completely? If that resident says, well, sometimes, or I'm not sure, or I don't think I empty completely, further follow-up is required. And then the last two things you want to assess, you want to ask that resident whether they require any assistance with toileting, and you want to screen for signs and symptoms of urinary tract infection. Now, as you know, current guidelines state that we should treat only symptomatic urinary tract infection. For patients with a catheter, they should have 2 signs of urinary tract infection. For patients without a catheter, they should have at least 3 signs. So those signs can be suprapubic pain, or flank pain or discomfort. It could be a change in bladder function, so increased voiding frequency, increased leakage. It could be a change in functional status, increased confusion. It could be a change in the characteristics of the urine. And then if you know 2 or 3 of those, you're going to do a urinalysis, and if that urinalysis shows positive leukocyte esterase, positive nitrites, that's another indication. A focused assessment will be done for any patient, any resident who triggers a positive response to any of the screening assessment questions. So let's go through what's involved on a focused assessment. Now, I just want to go back. If you do a screening assessment and the resident has no catheter, no problems with leakage, feels as if they empty completely, does not require toileting assistance, and has no signs of urinary tract infection, then no further workup is needed. But for a resident who does have a catheter, who does have problems with leakage, who is unsure of their ability to empty effectively, who does require assistance with toileting, or who does have signs and symptoms of urinary tract infection, they go to the next step, which is a focused assessment of bladder function. You should have a structured form. The history is usually carried out by the admitting nurse, and then the focused physical exam will be carried out by the physician or the nurse practitioner. So let's look at what's included on the history. This is the part that's carried out by the nurse. It takes typically 10 to 15 minutes to do this focused assessment. First of all, if the resident has a catheter, you want to determine, is that catheter medically necessary? A catheter is considered medically necessary for a patient who has retention that is symptomatic and that cannot be managed with intermittent catheterization. Retention is defined as post-void residual greater than 200 milliliters. Symptomatic retention is defined as either recurrent urinary tract infection or persistent leakage or evidence of upper tract damage. Clean intermittent catheterization is always preferred to an indwelling catheter, so there has to be documentation that the patient is not a good candidate for intermittent catheterization due to increased agitation or to severe contractures. There has to be a reason. Then the other 2 indications for an indwelling catheter, a stage 3 or stage 4 pressure ulcer on the trunk that is not healing, and the reason for failure to heal is believed to be constant contamination with urine. Short-term use of an indwelling catheter is indicated in that situation. And then, as you know, it is appropriate to use an indwelling catheter for comfort care in a terminally ill patient. Okay, now let's go on to the next set of questions. For the patient who does not have a catheter, but who triggered follow-up assessment by a positive response to one of the screening questions, we should ask these questions. First of all, do you know when you have to urinate? Yes, no, sometimes. If you know you have to urinate, can you hold your urine until you get to the bathroom? Again, yes, no, sometimes. Do you have any problems with urinary leakage? And if the resident says, yes, sometimes I have problems with leakage, then you do follow-up queries to determine triggering factors. Is that resident's leakage associated with activity? Laughing, coughing, sneezing. Is the leakage associated with a strong urge to void and they just can't get there in time? Or is the leakage associated with difficulty actually getting to the bathroom in a timely manner, transferring to the toilet, manipulating their clothing? In other words, the problems with leakage are associated with their problems with mobility. You also want to know how they've been managing the leakage up to this point. Have they been using pads? What have they been doing? And then finally, you do follow up in regards to retention by asking, do you feel as if you empty your bladder completely, and do you have to strain? Now, obviously, you can do this follow-up assessment only if the patient is cognitively intact. So if the patient is not cognitively intact, you would make that notation and you would not do this assessment. There are some additional questions you want to ask about factors that are known to affect bladder function. Hydration affects bladder function, so we want to know about usual fluid intake. You can start by asking the usual number of cups or glasses of fluid that they drink per day. But for many residents, it will be hard for them to answer that question. It may be better to ask them, what do you usually drink for breakfast? What do you drink between breakfast and lunch? What do you drink for lunch? What do you drink between lunch and dinner? What do you drink at dinner? And what do you drink between dinner and bedtime? You definitely want to screen for problems with bowel function, so you want to find out usual frequency of bowel movements, usual stool consistency, any problems with constipation, any problems with bowel incontinence. Okay? Medications, you want to be alert to medications that could increase the risk of leakage and medications that could increase the risk of retention. Typically, the pharmacist can help you do this screening. In screening for medications that increase the risk of urinary leakage, you're particularly alert to diuretics, to sedatives, to alpha-adrenergic antagonists. In screening for medications that increase the risk of retention, you're particularly alert to medications with any kind of anticholinergic component. Many medications have anticholinergic effects. And again, the pharmacist can be very helpful in identifying medications that could be contributing to retention if the patient has problems with retention. If the patient only has problems with leakage, no problems with retention, then you focus on, is the patient taking diuretics, alpha-adrenergic antagonists, or sedatives. And finally, you want to screen for comorbidities that are known to affect bladder function. Diabetes by causing polyuria, long-standing, poorly controlled diabetes because of the risk of autonomic neuropathy causing urinary retention. Any kind of neurologic lesion or condition definitely increases the risk for incontinence because it can impair the ability to transmit messages from the bladder to the brain and from the brain to the bladder. And then finally, as we have already discussed, dementia. So, what have we done so far? We've done a screening assessment. Any patient who responds yes to any of the screening questions is passed on to the nurse to do a focused history. The focused history addresses bladder function itself and factors affecting bladder function like fluid intake, bowel function, medications, and related conditions. The patient who has any kind of problem with bladder function should also undergo a focused physical exam that should be carried out by the physician or the nurse practitioner. And these are the elements to be included in the physical exam. First of all, what's this patient's mobility? Can they ambulate independently? Can they ambulate with assistance? Do they require a walker or a cane? Can they manipulate their clothing effectively, or do they have severe arthritis that interferes with that ability? Then you should move to an abdominal exam. The abdominal exam should screen for two things: evidence of obvious bladder distension, and in screening for obvious bladder distension, you percuss from the xiphoid to the symphysis. As you see here, normally the bladder is in the pelvis. And so you should be able to percuss from the xiphoid to the symphysis with no change in percussion note. If the bladder is distended, it will rise out of the pelvis into the abdominal cavity. In that case, there will be a change in percussion note, and that alerts the examiner to do a post-void residual to determine the level of retention. Then the second thing you want to assess for is colonic distension, because we know that if the colon is full of stool, if the rectosigmoid is full of stool, it's going to create bladder compression. It's going to interfere with bladder filling and may interfere with empty. So we want to percuss along the length of the colon. Normally, most of the colon is air-filled, so percussion should yield a relatively hollow tympanic note. Areas where the colon is full of stool, you will get a very dull note. Common to have dullness over the transverse colon because that's where stool is normally stored. So normal percussion findings would be tympanic resonant along the right colon, dullness over the transverse, tympanic resonant over the left colon and the sigmoid. But if I find dullness to percussion all along the length of the colon, it tells me that that patient has a colon full of stool and that I need to do a bowel clean-out. Women get a pelvic exam, men get an anorectal exam. The pelvic exam in women, we should be assessing for pelvic organ prolapse because that definitely requires medical management, possibly surgical management. We should be very alert to indications of atrophic urethritis, which you see right here. If the urethra is prominent and cherry red, if it looks like a miniature stoma, that tells you you have severe urethritis and that patient definitely needs treatment with topical estrogen unless there's a specific contraindication. And if the patient's able to cooperate, you want to assess pelvic muscle strength. That will be helpful to women who have problems with urgency and frequency. They can use their pelvic muscles to improve control. For men, the assessment should include a check for prostate size to detect prostate hypertrophy and assessment for sphincter strength. What about laboratory tests? Well, everyone should get a urinalysis to rule out evidence of infection, to rule out hematuria, to rule out glucosuria. So everyone gets that. Any patient with even one indicator of retention should have a post-void residual done. So if you have a resident who reports recurrent urinary tract infections, if you have a resident who is not sure that he or she empties consistently, if you have a resident who has a change in percussion notes when you percuss from the xiphoid to the symphysis, if you have a woman with major prolapse or a male with significant prostate enlargement, all of those patients should be evaluated with post-void residual. Most commonly in the long-term care population, we prefer to check residuals with a bladder scanner and ultrasound as opposed to in and out catheterization because then we have no risk of urinary tract infection. So always think about, do I have any indicators of retention? And if so, I want to get a post-void residual. If I have elevated post-void residual, I want to refer that patient to a urologist for further workup. Everyone who comes into the agency with any problems with bladder function, any problems with urinary incontinence, should get a 2-day voiding trial. If they can be ambulated with assistance and if they have enough cognitive function to respond to simple commands. Now, if a person comes to the long-term care facility and on admission, they are totally immobile, and cannot be ambulated with assistance. If someone's admitted with severe advanced dementia, no, you would not do a 2-day voiding trial. But for other residents, you will. So who needs a 2-day voiding trial? Patients who report need for toileting assistance, patients who complain of leakage but are able to respond to simple commands. This is what it involves. It's very simple. For residents who need assistance, you take them to the bathroom every 2 hours, you cue them to void, and then you record voided volumes. So this is a sample chart where you record the date and the time, the amount of urine voided, whether they voided spontaneously or in response to voiding cues. Document at the time of toileting, was the pad wet, and very helpful to indicate that it was damp, moderately wet, or soaked. We want to document fluid intake, and under comments you make a note as to how well the person responded to voiding cues, whether or not voiding cues were needed. Now you have your data. So you have your history, you have the data from your focused physical exam, you have your urinalysis, you have post-void residual if indicated, and you have the results of your 2-day voiding trial. You are going to now synthesize that data to determine what type of management program this resident needs. And it's going to fall into one of these 5 categories almost always. If you have a resident with a medically necessary catheter, you're going to put them on a meticulous catheter care program. If you have a cognitively intact resident who just needs toileting assistance, you're going to set up a toileting schedule, a toileting program for that resident. You may also want to do a physical therapy, occupational therapy referral to see if they can assist that resident to improve his or her mobility. For a resident with cognitive impairment who on the 2-day voiding trial responded to voiding cues more than 60% of the time, you'll put them on a toileting program, and we'll go over that. But I want you to pay attention to this. This is how we avoid wasting staff time. This is how we make the program relevant and manageable for the staff. We limit the number of residents that we place on routine toileting programs to those who are going to benefit the most. And we put the rest of the residents, those who do not respond positively to voiding cues, those who cannot be ambulated with assistance, those residents should be managed with absorptive products and skincare, as you see here. And then, as we've mentioned, patients who have overactive bladder syndrome and they're cognitively intact, they can be put on an individualized behavioral therapy program. So in our last 10 minutes, we're just going to go through specific strategies. You want to first begin with reversible factors. So for all residents, you want to put these interventions into place. Anyone who has a reversible alteration in mental status, so at the time of assessment you find that there's been a significant change in mental status, that's usually due to an unrecognized urinary tract infection, to some change in medications. So you always do investigation. You're going to do corrective therapy so that you get that resident back to baseline, okay, back to optimal function. So correct any reversible alterations in mental status always. We're going to treat symptomatic urinary tract infection as we have discussed. If you have a female with significant atrophic urethritis or with recurrent urinary tract infections, you're going to want to recommend topical estrogen unless there is some contraindication. The primary contraindication would be breast cancer. Other than that, topical estrogen is considered very safe since you have very low levels of systemic absorption. And topical estrogen is very helpful in reducing urgency and frequency, and improving pelvic floor health and reducing urinary tract infections. You're going to review medications with the prescribing provider and make changes if indicated if there are any issues related to medications. So if you have a patient who's having a lot of problems with leakage and you review the medications and the patient's on a diuretic, you're going to talk to the prescribing provider to determine, is there any change that can be made in their medication regimen? Maybe not, but it's worth a discussion. You want to treat any depression. You want to maximize mobility, as we have discussed, and you definitely want to prevent constipation. So a lot of long-term care facilities have made it a standard of care to treat fluid intake like medications, and to recognize that fluid intake is critical in preventing constipation. Fiber intake is equally critical. So in some long-term care facilities, they put either a fiber supplement or a combination of unprocessed bran and applesauce and prune juice on the resident's breakfast tray. And all staff knows that helping the resident to consume that mixture of fiber is a critical element when they're helping them to eat. So getting residents on effective programs with fiber and with fluids, recording bowel movements consistently, intervening promptly for any resident who fails to have a bowel movement for 2 days, so that we do not let our residents get constipated. Managing indwelling catheters, I think you already know all of this, but we'll go through it quickly. You want to use the smallest effective catheter, typically 14 to 16 French, to prevent trauma to the urethral walls. You want to limit the balloon to a 5 milliliter balloon inflated with 10 milliliters of water. A large balloon will cause a lot of trauma, or can potentially cause trauma to the bladder neck and can damage the sphincter. You want to stabilize the catheter either with a leg strap or an adhesive device so that there's no traction at the bladder neck and the urethra, so that you're not damaging the urethra. You want to maintain a closed system. That means you change the catheter and the drainage bag at the same time. You don't disconnect the catheter from the drainage bag. If you have a resident who uses a leg bag during the day and a drainage bag at night, when you insert the catheter, you should connect to the leg bag. Then at night, you should connect the leg bag to the drainage bag. In the morning, disconnect the drainage bag, but you never disconnect the leg bag. So maintaining a closed system, a very important element in preventing urinary tract infections. You want to work with your bedside caregivers. You want them to know how important it is to use meticulous technique in emptying the drainage bag. They should always have a clean receptacle, a clean graduate cylinder that's used only for that patient and only for urine. They should be very careful not to allow the spout to touch the side of the receptacle. In some agencies, they routinely clean the spout with an alcohol wipe prior to closure. So educate your bedside caregivers so that they're very, very careful when they're emptying the bedside drainage setup. Using very gentle technique and a pH balanced no rinse cleanser for meatal cleansing. Avoid soap and water. Avoid aggressive cleansing, because that can cause breaks in the mucous membrane that will in turn allow bacterial invasion. So very, very careful on meatal care. Adequate fluid intake, obviously. And then you want to make sure that all of your staff knows that leakage, when the catheter is patent, is an indication of a problem. Leakage should not be managed with a larger catheter or a larger balloon. The balloon is there simply as a retention device, not an anti-leak device. So you have to think, if my catheter is patent and I'm having leakage, what's causing the leakage? And the answer is increased bladder irritability. The bladder's actively contracting and forcing urine out around the catheter. That's usually due either to a urinary tract infection or a fecal impaction, something that is causing increased bladder irritability. For the patient who's cognitively intact and just needs toileting assistance, the issue, as we've said, is helping that resident get to the toilet in time. Now, we've all worked in a variety of healthcare settings, and we know that's not as easy as it sounds. So in addition to involving physical therapy and occupational therapy to improve mobility and dexterity, you want to work out a toileting program and educate the bedside caregivers regarding the importance of getting to that resident, taking the resident to the bathroom on schedule, and also the importance of responding promptly when that resident requests help with toileting. We do not want to make someone incontinent just because we're not available to help them get to the bathroom. So therapy consults, setting up a routine program and emphasizing the importance to that resident's caregiver, and also emphasizing the importance of responding promptly to requests. For our residents who have some degree of cognitive impairment and mobility impairment, but who meet two very important criteria, they can ambulate with assistance, and they respond positively to voiding cues at least 60% of the time. You're going to set up a schedule, a toileting schedule. In some agencies, they toilet every 2 to 3 hours. So some use Q2 hours, some use Q3 hours, and others use the schedule you see on the slide, where they toilet early morning, mid-morning, early afternoon, late afternoon, after dinner, and bedtime. Now, this program is totally staff dependent because it's the staff member that's going to go to the resident, take the resident to the bathroom, cue the resident to void. You have to get buy-in from the staff. And you do this partly by making sure that you limit it to residents who are most likely to benefit. You also want to tell the bedside caregivers up front, we realize that we will probably not eliminate incontinence in this individual, and we're going to use pull-up absorptive products as backup. But if we are able to significantly reduce the number of incontinent episodes, we can reduce the incidence of skin breakdown, and we can reduce the incidence of urinary tract infections. So any reduction is a plus for the patient and a plus for our agency. For residents who are totally immobile, for residents with advanced dementia, those who are not able to respond positively to voiding cues, you do not want to put them on a toileting program. You want to put them on a program with absorptive products and skincare. Now, it does matter what type of products, and you see the guidelines here. You really want absorptive products that have the polymers that wick urine and fluid away from the skin, that keep the skin dry. You want to make sure that residents are checked and changed every 2 to 3 hours, because more frequent changes improve skin health and reduce the bacteria on the skin, thereby reducing the incidence of urinary tract infection. And you want to make sure that these residents are being managed with appropriate skincare products. So they should be getting cleansing with a pH balanced no rinse cleanser, and they should be protected with a moisturizer moisture barrier combination. And then for residents who are cognitively intact but who have overactive bladder syndrome, urgency, frequency, nocturia, possibly leakage, these are residents that we can teach bladder control strategies. We want to teach them when you get that strong urge, don't run to the bathroom. Stand still or sit down to reduce all stimuli to the bladder. We want to teach them to use their pelvic floor muscles, so squeeze your pelvic floor muscles, specifically 3 to 5 quick flick. So contract, relax, contract, relax, contract, relax, at least 3. And then we want them to focus on deep breathing until that urge is under control, at which point in time they can walk to the bathroom. Freeze, squeeze, breathe. And of course, these are residents who may also benefit from low-dose anticholinergics. So there's the program. It's not overwhelming, but it does require staff buy-in. So what are the things you can do to overcome the barriers and to facilitate successful implementation? Well, first of all, make it easy. So develop the needed tools so people can see, hey, this is a very short screening assessment. It will only take me a couple of minutes, maybe not even 1 minute. And even the focused assessment is also pretty short. I can do that in 10 to 15 minutes. And we don't admit that many residents every week who would need that. So is that doable? Yes. And then I've got to get the nurse practitioner or the physician to do the physical assessment, but again, that's limited. We have the scanner, so it's not hard to scan anyone who needs a post-void residual check. You want to have a very simple protocol for your 2-day voiding trial. A form, very simple protocol that says who needs it, how is it done. And you want to have very simple management protocols. If you hand me a 3-page management protocol, I'm already overwhelmed. Keep it simple so that I get it and I've got simple guidelines and I can implement them and I don't feel overwhelmed. Education is critical. We want to focus on the benefits to the patient. What if it was you? What if it was your mom? We have to get administration involved because it has to be supported from top down. And a very simple thing we can do, this has worked in the area of infection control, has worked in the area of pressure ulcer prevention, is simply post data. Track data, post data. Keep people informed. Let them know. At this point in time, out of our 200 beds, we only have 5 residents with indwelling catheters, and they're all medically necessary. And we have a very low incidence of catheter-associated urinary tract infection. Let them know how many residents qualify for a toileting program, how many of them are on the toileting program, and what have been the positive responses. Let them know what are the number of patients who are being managed with absorptive products in skincare, and what's the incidence of skin breakdown. If I can see that what I'm doing is making a difference, if I see it in numbers and in outcomes, if you let me know what that patient's family member said about every time I come in, I notice that my mom is clean and dry, or I really appreciate that you're taking her to the bathroom. I see a positive improvement in her functional status. I'm really pleased with the care she's getting. That's very reinforcing. So in summary, what do we need to do? We need to screen our patients on admission and at routine intervals. Anyone who responds positively should get a focused assessment and then an individualized management protocol. And the most common protocols are listed right there. They're fairly simple and straightforward, And as long as we match the protocol to the patient, we should be able to get buy-in and we should have optimal outcomes. Thank you.